Hello friends, today I will be talking to you about PNH, that is paroxysmal nocturnal hemoglobinuria. Now, whenever you get a patient or you get a question where the main complaint of patient is that patient says, my first morning urine is black. This is the key word to diagnose a case of PNH. Key word. If you are getting this, it's almost a confirmatory that you are dealing with PNH. Now, what happened? Why is it so? Let's learn the basic. So, in the basic concept, you should know basic pathophysiology. The basic pathophysiology goes like this. That it is a acquired somatic stem cell mutation. This you know down. Okay, now stop writing and listen to me. First of all, it is an acquired disorder. That means it occurs after birth. Note down. After birth. Since the defect is after birth, so this cannot be heredity, so there will not be any heredity disorder associated with this. Second, it is somatic mutation. So that's why X or Y genes are not involved. Since it is a stem cell disorder, that's why in this all the three cell lineage, RBC, WC, platelet, all the three cell lineage are involved. This is the reason, because it is stem cell disorder. Now what happened? Mutation occur in PIG gene. What it lead to? It leads to deficiency of GPI. GPI is a anchor protein. Now, let's learn this information, what I have written for you. So you should, unless you know the basic, you will never understand PNH, what is happening. So till now, you are clear about it that we are talking about stem cell disorder. Now let's see, what is mutation of PIG and deficiency of GPI. Here is the blood vessel. This is the blood vessel. It has its cell, WBC, platelet, and RBC, whatever cell. So I am taking one cell. So in this, we have a membrane protecting protein. This is also known as membrane protective proteins. To this are attached membrane protective protein. So this is the GPI. Okay? Any cell, maybe RBC, maybe WBC, maybe platelet. So this is attached GPI, and to the GPI is attached CD55, which is also known as DAF, or CD59, also known as MIRL. So, to the membrane is GPI, and to the GPI is attached CD55 or CD59. And these two proteins, they are the membrane protective protein. What do you mean by that? In the blood, we have a C complement. We have a complement. This complement cannot enter the cell because we have a membrane protective protein, so-called CD59 and CD55. Let me make it little easier. Suppose this is a building like this cell, building, and this building has two gates, and in the gate number 1 we have a guard number 1, and we have a guard number 2 in the gate 2. So we have two guards, and this guard has a gun called CD55, and this has a gun. The name of gun is CD59. Two guards with a gun, and since guard is there at the gate with a gun, so this thief or chore cannot enter the building. This is the blood vessel. Okay, a complement chore is there. It want to enter the building, but it cannot enter. Now suppose this guard is on leave. These two guards are on leave. Guards are on leave. So no guard means no guns. No guard means no guns. Now there is no one to save this gate of the building. Now this C, thief, complement, can enter the cell and can destroy the cells. This is the basic funda of hemolysis. So now what happens? So as I told you, in PNH, there is deficiency of GPI. The GPI are not there. So no GPI. So there is CD55 and CD59 are deficient. Now what happened? This complement, it comes and it activates membrane activating complex, and that lead to destruction of all the 3 cell lineage. So remember, hemolysis occurs is intravascular because cells are broken down in the blood vessel itself. And number 2, it is an intrinsic disorder. I hope the problem lies in the intrinsic disorder in the cell itself. So as there is intravascular hemolysis, I hope all of you know the basic pathophysiology of hemolytic anemia. As the cell RBC is broken down in the blood vessel, hemoglobin in the cell is released into circulation. And ultimately this hemoglobin is filtered in the urine, and that we get hemoglobin urea, and which give rise to black color of urine. I hope you remember, like we have an intravascular hemolysis in the Plasmodium falciparum infection also, which is a type of what? Black water fever. Why black water fever? Because of intravascular hemolysis, hemoglobin urea occurs, same thing happen, so we get black color of urine. Now the question is, why it happen? Why we are getting first morning urine sample black but not in the daytime? It means the intravascular hemolysis were occurring at night. At night, intravascular hemolytic anemia. Why? What happened? At night, when we all sleep, you sleep, I sleep, we all tend to have some mild hypoventilation. Hypoventilation. So we all have a normal tendency to have a little mild hypoventilation. That's why we all tend to retain CO2. We tend to retain CO2. So there is mild increase in CO2 level in the blood, and that lead to mild respiratory acidosis. So there's mild respiratory acidosis occur. And these complement are active only in acidic media. That's why hemolysis occur at night only. So when the patient gets up, goes to toilet in the urine, to pass urine in the morning, so we get black color of urine. But in the daytime, when the person is active, this acidic media is not there, and as there is no acidic media, the complement is not activated, so hemolysis does not occur. So now you are clear why we get only first morning urine sample as black. Okay? So now let's talk more. So we have understood the pathophysiology, that is a somatic defect, intrinsic defect. Now what else happened? As I told you, the breakage of all three cell lineage occur because the CD55 and CD59 are deficient in all the three cells, RBC, WBC and platelet. So that lead to pancytopenia. This is a very, very important and frequently asked question. But remember, the problem is all the destruction of cells is occurring in the peripheral circulation, but the bone marrow is hypercellular. Hypercellular bone marrow. This is a very, very important, and I think this question comes every year in the PG entrance exam. In which condition you get pancytopenia with a hypercellular bone marrow? Answer shall be PNH. Now what else happened? Now in this condition, platelet count is reduced. So, and you know, any condition where platelet count is reduced, patient is prone to bleeding. But in this case, something unusual. Despite thrombocytopenia, there is tendency for increased thrombus formation. Thrombus formation. This is something paradoxical. We expect more bleeding, but patient is more thrombus formation. Why? When the platelet is broken, suppose it's a platelet P is broken down. Okay, platelet broken down, it releases ADP in the circulation. This ADP causes more and more platelet aggregation. This has a platelet aggregating property. So despite having low platelet count, there is aggregation of platelet, and that lead to clot formation, thrombus formation. In fact, cortical vein thrombosis, vein thrombosis is the most common cause of death in these patients. So we are getting thrombus, cortical vein thrombosis. Of course, it can cause pain abdomen, again due to thrombus in the mesenteric vessel. What else we get? In this case, LAP score is reduced. Leukocyte alkaline phosphatase score is reduced. It's a very frequently asked question. And what else is there? In these patients, aplastic anemia can develop. Patient bone marrow failure can happen. Remember, usually it is hypercellular marrow, but even aplastic anemia can occur. And second, in these patients, patient may develop acute myeloid leukemia. So there can be bone marrow failure, or patient may develop acute myeloid leukemia. Now, how to investigate these cases? Nowadays, the most accurate test or most confirmatory test is flow cytometry. Okay, this is the most accurate test. In this, we can detect reduced level of CD55, CD59. Okay, this is the most confirmatory test. Very, very important question you got to remember. Right? Previously we were doing sucrose, lysine tests, etc. They are no more used now, but this is the only thing what they are going to use this patient. Now, how to treat? Remember, patient can come with the acute hemorrhage. How do you know? First morning urine sample black. Otherwise, patient even can have chronic hemolysis also. Now, suppose patient has come to you with acute bleeding. He says, Yaka, I am getting black color urine for last few days. That's the acute hemolysis. In treatment of acute cases is always prednisolone. Remember, again repeating second time, in acute cases the drug of choice is prednisolone. But in chronic cases, we use eculizumab. It's a complement inhibitor. Got it? The point to be noted, this is for chronic, more of a preventive, and this is to stop acute hemolysis. Okay? So this is all about PNH. Now let's see what all important point you have to remember. First and the most important, first morning urine sample black is PNH. Number two, it is an acquired stem cell disorder. Three, there is deficiency of GPI. Fourth, and there is deficiency of CD55 and 59. Point number 5, we also get thrombosis. Point number 6, LAP score is reduced. Next, point number 8, most common cause of death is cortical vein thrombosis. Point number 9, patient may develop aplastic anemia, acute myeloid leukemia, acute or chronic hemolysis. Okay? And point number 10, flow cytometry is the most confirmatory test. And point 11, there is pancytopenia with hypercellular bone marrow. Point number 12, for acute bleeding we use prednisolone, and for chronic prevention we use a complement inhibitor, eculizumab. Okay, friends, as I told last time also, I'll be taking regular lecture. The next lecture is about congestive heart failure, about which you are well aware, or my staff will post all the details. And soon, because I got suggestion that I should post some MCQs with expert answer also. So we are working, I have talked to my technical team, maybe that very soon we like to post after the lecture some MCQ on the same topic with the explanatory answer. You do the question, you see the answer, and you assess your progress also. So thank